may I introduce our next speaker, who is Professor Miia Kivipelto, Professor of Clinical Geriatric Epidemiology at the Department of Neurobiology, Care Sciences and Society, Karolinska Institute. Professor Kivipelto was appointed Professor of Clinical Geriatric Epidemiology at Karolinska Institute at 2011, and she is also Director for Research and Development of Team Aging at Karolinska University Hospital. She has previously worked on assignments for the Swedish Council on Health Technology Assessment and the National Board of Health and Welfare. Her research interests include risk reduction for dementia in later life through a number of preventative measures, including identifying and addressing risk factors that occur in middle age, including high blood lipids, high blood pressure, in addition to physical activity. In addition, early diagnosis and prevention are an important component of Professor Kivipelto's research. So I would like to welcome you once more, Miia, and it's a pleasure to have you with us. Welcome, and the floor is yours.
Thank you, Eva, and thank you for the Alzheimer Europe for the invitation. It's a great pleasure to be here, and I fully agree. It's so exciting time now in the Alzheimer research. So I will follow Philip's and Frank's excellent presentations, focusing more on the prevention. And just more as a background reflection, we all know that dementia is a huge challenge globally. The numbers are increasing because we are living longer. And prevention has been highlighted as the key element if we want to manage this global dementia epidemic. And when I'm talking about prevention, I really think both non-pharmacological and pharmacological interventions. This is the direction where we are moving. I think prevention is the treatment what we are having starting earlier and earlier. And I think these new advancements, seeing Alzheimer's as a spectrum, is really opening the new keys for that. Before I move on, I still want to give another reflection, the landscape. We still think there was a nice report from ADI showing some years ago that still 60%, even healthcare professionals, are thinking that Alzheimer and dementia are part of normal age. And around 1/4 of the people think there is nothing we can do to prevent. There is a lot of stigma. So we need to keep in mind this landscape, what is there when we are thinking prevention. And I really believe that these new biomarkers, this awareness will help us also in the prevention. So during my presentation, I will, let me see if I can move on. Yes. I will talk about what we know about prevention, especially focusing on the multi-domain interventions. Lessons learned from Finger and worldwide fingers. How should we think about prevention during and after the COVID pandemic? And what are the future directions when we are moving from the complexity more to the precision prevention? So the question is, to what extent we can prevent dementia and Alzheimer's disease? We do not know yet the answer, but the most latest estimate comes from the Lancet Commission paper. And I think it's a very optimistic because the list of modifiable risk factors has been increasing so rapidly, and is pointing now that around 40% of dementia is linked to modifiable risk factors, meaning that there is clearly a prevention potential, several targets and several timelines for the interventions. You can see here the risk factor list. We have these older risk factors like diabetes, high blood pressure, obesity already at midlife, physical inactivity, depression, smoking, low education, but also some more novel risk factors like hearing loss, which has been getting a lot of interest and is very common, especially among older people, social isolation, even air pollution. If we turn the discussion from risk factors to protective factors, what can we do? Here, of course, we have the healthy, balanced diet and in general, active lifestyle when it comes to physical, mental, and social activities. And I believe that this list is not yet the final. There is a lot of research going on trying to identify even more novel risk factors. Not only depression, but also feelings of loneliness and hopelessness. I would say that these are getting more attention during the pandemic lockdown, especially when older people have been more isolated. Stress and sleep disturbances. We see this more and more even at our memory clinics. Even younger persons have challenges with stress and sleep, and these are also linked to increased risk of cognitive impairment and dementia. Impaired oral health and infections. Of course, COVID-19, there is intensive research going on trying to understand if we can also increase the risk of cognitive impairment and even dementia. I think when we are looking at this list, it's important to keep in mind that the evidence level for different factors is varying. For some of those, like vascular, physical activity is already strong, and for others, like air pollution and hearing loss, is still a bit more limited and more studies are still needed. My team has been working with WHO with the first risk reduction guidelines, which were released 2019. And we went through in a very systematic way the evidence for all these different risk factors. I think this is a very significant document because it provides a strong evidence base for different countries when we are planning the implementation. And I think the message is quite clear. We start to have enough evidence to justify immediate actions, how we can start to implement these findings for risk reduction. Then the question is, what do we aim to prevent? We already heard that dementia is kind of the final stage. It's a long process, which may start in the brain 20 or 30 years before the person is reaching the dementia stage. And we aim to start all interventions earlier and earlier when people have mild symptoms and actually more and more at risk stage. How to define the at-risk stage? We heard already about these different biomarkers which can be conducted, neuroimaging, CSF, and importantly, the blood-based biomarkers, which are, of course, giving the possibility to scaling up this much more. But we could also identify these at-risk persons focusing on modifiable risk factors. This could be added to this kind of risk score. And this is especially important, I'm thinking, when we are talking about lifestyle interventions. We know, we have learned, as Philip and Frank mentioned, that especially older age dementia is often mixed, and there are different pathologies, not only Alzheimer, but very often also vascular pathology. And late life dementia is indeed very heterogeneous, and that's why we believe that multi-domain preventive strategies are needed. So this is important when we now are moving from the knowledge about risk factors to clinical trials and sustainable implementation. Keeping in mind this complexity, the multifactorial etiology of dementia, and I mentioned the concept multi-domain interventions. There have been several single domain interventions, for example, focusing only on physical activity or some single nutrient. And the results have been quite modest or negative. And we believe that if we really want to prevent in an optimal way, we need to target several risk factors and mechanisms simultaneously to get more optimal preventive effect. At the same time, what we have now learned is that one size does not fit all. We still need to learn more about this heterogeneity and mechanistic foundations so that we can tailor the interventions to specific at-risk profiles and to different settings. Finger trial, which I have been leading, was the first large-scale randomized control trial, really showing that it is possible to prevent cognitive decline among at-risk older people from general population. We identified the persons using the GAID Dementia Risk Score, very simple, only having easily available factors like high blood pressure or physical activity, or what is the body mass index. And the multi-domain intervention was this one-hand, five-finger model with nutrition, exercise, cognitive training, social activities, and taking care of all vascular risk factors for 2 years compared to regular health advice. We are now starting actually the 10-year follow-up for the finger after the summer. I think it's very exciting to see also the more long-term effects of this type of intervention for clinical outcomes. Feedback from the participants have been very positive. They especially like the social part of the intervention. Adherence was good, so this is important to see that this type of intervention is feasible, and the dropout rate was very low. You have probably seen the results earlier, so this is only the very brief summary of the finger results for cognition. Global cognition, 25% more improvement, and importantly, all pre-specified cognitive subdomains, executive function, 83% more improvement, processing speed, 150%, and memory, 40% more improvement. And the control group had 30% increased risk of cognitive decline already after 2 years. On top of that, there were clear benefits on other important outcomes. Functional decline and mobility, better health-related quality of life, and quite surprisingly, 60% lower risk of other chronic diseases, especially the multimorbidity, which is very common among older people. And related to that, 20% lower risk of hospitalization and health economic benefits. So we can say that the same kind of package can give beneficial effects for the brain health, but also for the global, more general health on individual level, but it may also have wide implications on the more societal level if we can successfully implement this. One question which I often get is, are people really able to keep this healthy lifestyle after 2 years? And now we start to have some data after 7 years. And here you can see results for the dietary intervention. The red one is the intervention group. After first year, the dietary habits are improving a lot. After second year is declining a bit because the intervention was more intensive during the first year, but it's still significant compared to the control group. And as you can see, still after 7 years, there is a significant difference between the control group and the intervention group, which I think is very positive observation. So elderly persons are able to change the dietary habits, but they need advice, they need counseling. And what I think was also quite striking was that the so-called control group who received regular health advice, nothing happened in the dietary habits, even though they were told that you should eat in a healthy way. So people need a little bit more hands-on support to do these more long-lasting changes in the lifestyle. Finally, a few words about the worldwide fingers. There is a great need to test, optimize, and adapt the finger model in different settings and in different cultures. And to support this, we launched Worldwide Fingers 2017. We have also a unique opportunity to use a prospective harmonization in the trials so that we have easier to compare the results after the trials are conducted. And also sharing experiences and data, especially countries who have not been conducting so much trials have felt that this is a great opportunity to learn and get the support needed to start this kind of interventions in different countries. And I'm very happy that now 2021, we are having 40 countries from all continents who are part of the Worldwide Fingers Network, including several low middle income countries. I would say that Europe is really the leading here. We have the long tradition for risk reduction work. So this is our goal, that we keep this leadership and we move on in this field. Of course, COVID-19 was a huge challenge, and we have been trying to analyze how this pandemic has been affecting the trials, but also how it has been affecting people's lifestyle. There are also these not only direct effect of COVID infection on brain and other organs, but also the indirect effect because of not so easy access to the healthcare and this lockdown effect of people's lifestyle. So what we did was that we developed a survey, COVID-19 survey, in collaboration with WHO, Neurology and COVID Global Forum. And now around 30 countries from Worldwide Fingers are participating in that. So we will surely get interesting data from different countries. This is just a short snapshot from Finland. What happened during the pandemic? This is data after the first wave. And as you can see, the pandemic had clear negative effects of people's lifestyle. 30% are reporting less physical activity. There are more loneliness. People are feeling that memory is not working so well. And a lot of cancellations in different kind of services like dental health. The positive thing was that people were able to keep up quite healthy eating habits and also use more digital tools, which is important, especially when we are now aiming to develop the e-fingers concept. Frank mentioned that very nicely, that digital tools are really important, and I believe that it's not only the monitoring, but they can also help us in personalized, effective, and feasible interventions and implementation. So this is clearly an important area in our research and in clinical practice. And my final example is the combination. Finger 2.0. I don't think it's only lifestyle or drugs, but to really get the optimal effect, we should try to combine non-pharma and pharma interventions. And I'm very happy that in Europe, we have had this GPND-supported MIND-AD consortium, where we did the first combination therapy using the finger model for patients who had early Alzheimer, prodromal AD, defined with these biomarkers Philip and Frank mentioned. And on top of that, they also had some vascular and lifestyle risk factors. Experiences have been very positive. I would say it's never too late, even for persons who have early AD, or maybe especially for those, we should really try to implement this type of lifestyle package. And in one arm of the trial, we combined the finger lifestyle intervention with medical food to see if we can get even better effect, more synergistic effect for this. And for this trial, we selected the medical food Frank mentioned from Lipid Diet EU consortium. It's a multi-nutrient that has been specifically designed to support the synaptic function in the brain. And as you heard, the results from the Lipid diet have been very promising. And also what's interesting to see was that the results got more clear after 3 years, both for cognition, function, and brain atrophy. So that's also from the methodological point of view important. If we start early, we also need to have quite long follow-up time in the trials. And the next step, we want now to take even further step and combine the finger with the drug. And in this Midfinger trial, which we are starting after the summer in Sweden, Finland, and UK, we are combining it with metformin, diabetes medication, as a repurposed drug approach. Diabetes and AD have been linked. I see this as a model. Maybe in the future, we can combine this with more specific Alzheimer drugs as well. And now, as part of our EU Fingers Consortia, GPND funded, we are developing tools for this direction. Philip and Alzheimer Europe are part of our consortia. And here we want to develop tools, not only to measure the risk, but also to measure the prevention potential. How can we combine and have the protocols for combination therapies, develop online registry, guidelines for clinicians, how to have the disclosure for biomarkers, and how to involve our participants when we are designing the trials. I'm very happy that Alzheimer's Europe is part of this and conducting these PPI activities. I think it's very important for our trials. So summing up then, what can we do to prevent, or can dementia and AD be prevented? I would say yes, a significant portion of cases can be prevented or at least delayed. I personally prefer to use the term risk reduction, not maybe prevention. We have evidence from Finger and from some worldwide fingers that this multi-domain model is feasible and effective. And now we are learning more from different worldwide fingers countries to develop more sustainable models in different societies. COVID is a challenge, but I think prevention is even more important. And here we really need to have innovative approaches and joint efforts. And for the future, we are moving from the complexity to precision prevention. We need to try to tailor the interventions for specific at-risk profiles, combine lifestyle, nutrition-based interventions and pharma, and use the new technology, the concept e-fingers. I want to stop here and thank you for the listening, and then I'm happy to take some questions.
Thank you very much, Miia, for your exciting presentation, and not only for the exciting presentation, but especially for long-term collaboration with Alzheimer Europe, which we really appreciate. And also this thanks goes not only to you, but also to our other speakers during this meeting. And I personally especially liked the term hands-on in prevention, which we know what's hand-on in care, but it's also important in prevention, just explanations and guidance of people. And I think it is very, very, very underestimated still in many countries. And it is a similar remark that also Jean has written into the chat. May I read it? Great overview of the important potential impact of prevention. Isn't it time to translate this into public health campaigns and messages? Are you aware of countries successfully using prevention messages in public awareness campaigns?
That's a very good question. And I think it's time to act. As I said, we start to have enough evidence to justify immediate actions. Of course, we need to refine the evidence, find even better models, but we have enough evidence to do something and increase the awareness. As I said, still so many people do not even know that there are modifiable risk factors, so there is so much to do. I think we can partly use the integrated interventions because there are campaigns for other diseases and the risk factors are partly the same, but I don't think it's enough. We need to have more specific campaigns for brain health. Brain health motivates people. They want to know what is possible to do. We have started some campaigns in Nordic countries, especially in Finland, but they are still a lot to do, I would say, but it would be lovely to see and collect some positive examples and really try to do something. I would like to see something like that, like having something like very simple finger model when you are sitting at the GP, that people really take it closer to them, that there is something I can do today to try to work for my brain health. So we should maybe take it more on that level as well, that is more visible and more easy to understand for all people. So here really joint efforts between different stakeholders are needed.
Thank you very much. And I hope that you will join us also into the final discussion. And
I will stay here, absolutely.
Yeah, thank you. Our pleasure to have you with us.